Hi, my name is Caitlin Taylor. I'm a breast medical oncologist at Ochsner MD Anderson Cancer Center, and I'm pleased to be here today with Dr. Andrew Davis, and we're going to be having a conversation about Camizestrant.
My name's Andrew Davis. I am from Washington University in St. Louis, the Siteman Cancer Center.
All right, well, great to have you here and looking forward to our discussion today. Just to kick things off, could you, why don't you give us an overview of the Serena 6 study? I know there's been a lot of discussion about that recently and certainly mixed reactions to the data. So maybe give us an overview and sort of set the stage for our discussion, if you could.
So Serena 6 was presented last year at the ASCO plenary. It garnered a lot of attention and excitement. It was, in some sense, a paradigm shift in how we think about treating patients with metastatic breast cancer. The idea is for patients who are on first-line treatment with a CDK4/6 inhibitor and endocrine therapy to monitor those patients with what's called ctDNA or circulating tumor DNA and look for the emergence and detection of what's called an ESR1, an estrogen receptor resistance mutation, and then to intervene with an oral SERD called Camizestrant. And it was a randomized study, meaning that half of the patients who developed the ESR1 mutation were randomized to switch their endocrine therapy to Camizestrant, while the other half of patients did not receive the Camizestrant upon the emergence of the ESR1 mutation. And what the main finding of the study was that patients were able to stay on that line of therapy, essentially that progression-free survival was longer when Camizestrant was initiated when the ESR1 mutation was detected without any evidence of clinical or radiographic progression of disease.
Thanks. That was a great overview. I thought this trial design was so unique and really set the stage for thinking about proactively responding to tumor changes rather than reacting at the time of radiologic progression like we normally do. One thing that I think maybe hasn't gotten as much attention as it should is, some of the data that looked at the complete clearance of the ESR1 mutations. I think that was presented later, maybe at San Antonio. So if you could comment on that and really, some of the ctDNA clearance data and specifically why that is, kind of worth digging into a little deeper.
As far as ctDNA, it essentially serves as an early marker potentially of response or resistance. And across many trials prior to Serena 6, we've seen that we can basically detect progression of disease or response based on clearance or increase in ctDNA. So it's exciting to see when ctDNA is decreased or even cleared, that's a good sign in terms of we are targeting the actual mutation, ESR1, and having it cleared to prevent or anticipate that progression of disease so that does not happen.
Yeah, I think it, really the efficacy is there. That data really supports that. And it does make us think about really the importance of keeping patients on that first line treatment as long as possible. Certainly from a treatment perspective, but also just from like a quality of life standpoint for patients. I think sometimes that time of first progression is tough for people. And so, sort of along those lines, I think, there is this unmet need of, thinking about why early action matters. And so, before disease progression. So, if you could speak on, the importance of kind of what this trial brought to light, potentially acting before radiologic progression, and what that means really for patients as well.
I think you brought up a couple of very important points. I think one is we think that acting earlier matters. I think intuitively that should be the case. And it's difficult, it's challenging to design the right trial to be able to show that. But I think what made this trial potentially very meaningful is we were targeting a specific mutation that we know to cause resistance in up to 40 or 50% of ER positive,
Sure.
HER2 negative breast cancers. And it's something that we also know that if we wait to initiate an oral SERD until the second line, unfortunately, those drugs do not work as well as we would hope. So the idea is, can we use these drugs earlier in order to improve clinical outcomes and keep patients on first-line therapy longer?
Sure. I guess let's dig into the, the quality of life aspect a little bit more for patients. Certainly keeping patients feeling as well as possible for as long as possible is really our goal with metastatic disease, right? That's what we're all aiming for. The thought of switching these patients earlier, there is a question of, keeping them feeling well, keeping them symptom-free from progression, of course. But then additionally, the data show that patients on Camizestrant really felt well. Side effects were all grade 1, grade 2 for the most part. So tell us a little bit more about kind of how you would think about that as far as sequencing and, when someone is coming off of progressing on that first line therapy and sort of side effect management and, I don't know, what would make this more appealing for you to reach for potentially?
I think broadly speaking, when we think about drugs that are going to help patients, we want drugs that are going to help patients live longer or live better with improved quality of life. And importantly, this trial did show improvement in quality of life with this early switching strategy. I think there are a couple of factors that are important in that. One is, how well is the drug tolerated? If we were switching early to perhaps a chemotherapy or an antibody drug conjugate, that may cause more toxicity from the actual drug. And then, as you pointed out, there's also the consideration of preventing symptoms related to disease. And that's, of course, a significant concern in our patients, whether it's bone pain, shortness of breath, or other symptoms. We want to do everything we can to maintain patients feeling quite well for as long as possible.
Okay, so let's talk a little bit about, dig in a little bit deeper, I guess, on why intervening early could potentially be helpful. I know, again, as we touched on at the very beginning, there have been sort of different takes on the data and the study design. Certainly, understandably, I think there are a lot of things that are still immature, right? Overall survival, things like that I think we don't have the full story yet, but I think for you in practice, I think thinking about sort of this early intervention strategy, how would you implement that? And I guess even now, how are you sort of going about doing, molecular testing, and at what time points? In the study, their patients were checked every 2 to 3 months. Is this something that you would sort of coincide with scans, or kind of talk me through how you would think about that clinically in your practice?
All very important questions. I think there's, the intricacies of a clinical trial design and also how to implement something into clinical practice. And sometimes those two can be a little bit different. I would say in general, I've been a big proponent of liquid biopsy and ctDNA and how that can impact clinical care in the metastatic setting. I think one of the considerations or potential challenges is the frequency of ctDNA testing. And in the trial, the specific focus, of course, was the ESR1 resistance mutation. But you can imagine in clinical practice, when ordering ctDNA, it is likely that we'd be getting broader panels with more and more mutations. So I think one of the questions I have is, if we're doing this serial monitoring and we see development of different mutations, some clonal evolution that's not ESR1, how do we handle that? What does that mean? And I think those questions still need to be answered.
Yeah, I think that's a great point. Another thing that I've thought about along the same lines is, if you're monitoring that and someone does happen to show we know not all progression is created equal. I think we all think about maybe a tiny bit of progression in the bone differently than we do other types of radiologic progression. But let's say you're starting to see some of that, do we then sequence in some of these other oral SERDs? Kind of what does that look like moving forward? Or do we take that as, these tumors have declared themselves as no longer being endocrine sensitive, period, and, we need to move on at that point.
I still think in clinical practice, the definition of endocrine resistance can be tricky.
Absolutely.
Based on blood tests, based on radiographic features. I think looking at some of the second line SERD trials like Emerald, we see that even on the oral SERDs, maybe 40% or more of patients have progression at that stage over after 2 to 3 months, really the first scan that's done.
Exactly right.
So I think that gives us a signal that earlier is better. I think the other thing, that's been brought up as a controversy is whether or not the control arm should have crossed over. Right. I think it's a reasonable thing to debate. I think it's a reasonable criticism, but I think the challenge is that in clinical practice in the second line, we don't just give oral SERDs for ESR1 mutations. We give oral drugs for PIK3CA mutations. We, in some cases, decide to give chemotherapy or antibody drug conjugates. So I think there would have also been criticisms or limitations to say that everyone in the control arm would have needed or required to receive an oral SERD at the time of clinical progression. So I think it's probably a situation where there was no perfect clinical trial design, but I think, certainly interesting conversations and debate surrounding it.
Yeah, absolutely. And I think it does really set the stage for kind of other trial design and just thinking about how we practice, like I said, of choosing therapies sort of proactively at the time of molecular progression rather than radiologic progression, and what that means both for patients and for us as providers. From a patient standpoint, I think, gosh, what would be, if we were to be doing this in practice now or in a future state, what is the additional burden to a patient? I know a lot of patients sort of talk about scan anxiety, which, they're already living with every 3 months typically, and, does this this is obviously another piece of the puzzle that you would want to have at that visit where you're discussing scan results to say, things look good here, but we're seeing this. Or, on the flip side of that, do patients feel more empowered? Thinking about, gosh, well, we are able to anticipate, the minute this cancer is changing. And so I think thinking about it from that standpoint is interesting.
Yeah, I think there are patients who do feel empowered, having access to more information, really being actively involved in the care team and decision making. I also have some subset of patients who probably want to know less and are just
Agreed.
Comfortable with the status quo. But I think when we think about both treating patients with metastatic disease, but also transitioning these technologies, the minimal or molecular residual disease in the neoadjuvant or adjuvant setting, I think these technologies are entering clinic now, and we really need to understand how can we optimally utilize them in patients to ultimately improve outcomes. And I think thinking about testing anxiety is an important feature of all of this, and the frequency of testing as well.
Yeah. I think, and to your point, that subset of patients who really sort of less is more, they would rather just I think that extra data can be overwhelming. Mm-hmm. And, if you have someone who really is feeling well on their AI and CDK4/6 inhibitor, I do think sort of it is tough to then insert this another unknown, even though we can say that, objectively patients tolerate this well. I think it's still an unknown agent. And so for someone who's otherwise feeling okay, I do think that sort of is another layer of complication to add in something new, especially when right now, again, we just don't have the full story yet as far as, is this going to change things in the longer term?
Mm-hmm. And I think, as I mentioned earlier, in the trial, the data were reported as ESR1 or not, mm-hmm. but you can imagine, and of course patients should have access to all of their information, but receiving a report every 2 to 3 months with 10 different mutations and different allele fractions and things going up and down. And I think there needs to be a system in place of addressing that with patients for their understanding and, as you said, empowerment, so that they can really understand what these things mean. Because I think as oncologists, we are beginning or have a solid understanding, but there's also limitations in our own understanding of what some of these different mutations mean.
Yeah, absolutely. I agree. I guess let's talk a little bit about sort of the limitations and controversy of the data. I know we've sort of touched on that a little bit. As we think about keeping people on first-line therapy longer, we know there's so much benefit to be had there, but certainly people have had mixed reactions to the data and thinking about sort of how things should be interpreted. What do you see really as some of the biggest limitations?
I think when I first heard about the data and read the New England Journal of Medicine article, I think one of the concerns I had was that the patients in the Camizestrant arm were getting an additional therapy and counting that as first line. But I would say the more I thought about it, the example trial that I thought about was the Patina trial, where patients with HER2 positive breast cancer, a different setting, of course, receive kind of induction therapy, and then if they're ER positive and HER2 positive, they get palbociclib plus continuation of the HER2-directed therapy. And I think seeing how good outcomes are with that strategy of adding on a CDK4/6 inhibitor in that setting, and sure, it's still considered that first line of therapy, but I think adding in a drug that's well tolerated in the first line to extend first line for as long as possible, I think is a strategy that's ultimately, I think, going to be beneficial to patients. But of course, we need to see overall survival data and more maturity of the data that will be reported out. Yeah,
I totally agree. I think certainly being able to extend that time period that tumors are endocrine sensitive is huge. If we're able to do that, we know that with each subsequent line of treatment, typically patients are on that for a shorter period of time, right? And so if we can maximize that upfront treatment, then I think that's setting patients up for better longer term outcomes. And really delaying, time to chemotherapy, that's another big thing that I think that transition from oral agents to having to go to chemo is a big step for patients. And the longer we can delay that for people, certainly the better. Mm-hmm. So let's talk a little bit more about quality of life for patients. We've touched on this a little bit, but the data show that really patients do tend to tolerate the Camizestrant well. The ocular toxicity really ended up being fairly mild and really did not impact quality of life significantly, which I was pleased to see. So, tell me a little bit about how you think about that and just big picture patients' quality of life, again, in sort of a future state if we were to implement this strategy.
I think it was very important to see quality of life benefit, especially given the maybe controversy surrounding the progression-free survival and waiting to see overall survival data. I think quality of life is central and very important to consideration of drug approval. And I think it's also, as we talked about, important to delay initiation of chemotherapy or antibody drug conjugates for as long as possible. I think once we get to that point, and right now we basically have capecitabine, but all other chemotherapies are infusional. And I think it's a very tough transition for patients to be on oral therapies for some period of time and then have that conversation of, well, we need to, or think about putting a port in. That's something that in all likelihood is going to be with you for the rest of your life. Some of the chemotherapies cause hair loss and other toxicities that I think can impact quality of life in their own right. So I think delaying chemotherapy for as long as possible is a collective goal in treating and managing metastatic breast cancer to really make it a chronic disease that we can use oral therapies for as long as possible.
Yeah, I totally agree. I think also just to point out, patients who struggle on aromatase inhibitors. Here is an option where people really did, again, some of the side effects seem to be fairly mild and patients really did seem to feel better on this. Now, in the trial, it is a little hard to know, is that specifically from the switch off of the AI or is that because we're keeping them in a state where they're not progressing longer, right? So I think teasing that out is a little tough, but it did seem like patients generally felt better on this. So that's another thing that, I think about as far as how I would potentially implement this in clinic and talk to a patient about it, about potentially switching earlier.
And I'll tell you, I have a lot of patients who, when I describe fulvestrant and I describe oral SERDs,
Right.
I would say almost everyone would say, well, I'd much rather take a pill than having injections every month for some period of time.
Exactly.
So I think just the administration of a pill is nice from a quality of life standpoint.
I totally agree. And just time away from clinic and the infusion center. I think that's a big one. Even if patients are doing well, still having to come in, go to the infusion center to get the injection can be tough. And so I think in oral agents, as long as we're able to use those, are certainly, for the most part, seem to be preferable to patients. I agree.
And I think, it's nice you brought up the point of time away from clinic. I can imagine a future where we can do home blood draws or really blood draws to look for ctDNA outside of the clinical setting.
Absolutely. And
that could potentially lead to situations in the future of delaying scans, less clinic appointments. So I think that future is coming. We're not there yet.
Yeah.
But I think there have been some smaller trials in other settings that have shown that kind of decentralized hybrid designs that ctDNA can really be easily performed outside of a traditional clinical setting.
And that's a great point you bring up as far as, kind of following things from a molecular progression standpoint, maybe rather than a radiologic standpoint. Obviously that the scans will always be there, but sort of thinking about the spacing and timing of those in conjunction with when we're doing some of the molecular testing. And as long as things look good from that standpoint, are we more comfortable delaying things?
I wish we had more studies showing that, because I think the tendency in oncology is to always do more. And
right.
Of course, I'm supportive of that. But I think we have such strong data that ctDNA clearance or reduction is associated with good clinical outcomes that I could see, again, a future scenario where we space out scans, we look for ESR1, we look for other driver or resistance mutations, and we do less scans as a result, and really use the scans when we see a signal from ctDNA to define where the disease is, not just that there is progression.
Yeah, it does seem like that would be such a, a patient-centered way of practicing as we move forward. Okay, so do you think that there are, I guess, sort of overlapping with quality of life, but, safety topics that you think clinicians in the community would want clearer perspectives on as it relates to camizestrant?
I think the two toxicities to be aware of would be the ocular toxicity and also the potential cardiac toxicity. I think these rates are relatively low, few high-grade toxicities, but I think awareness is important, and basically having, if a toxicity is to develop, make sure that both patients and doctors and other providers are aware. We have so many new drugs coming through the pipeline in oncology and breast cancer and other tumor types that having that awareness among doctors, nurse practitioners, PAs, and patients is critical.
Yeah, I agree. I think, like you said, we have so many new agents now to keep track of. And I think a lot of it is just, a personal comfort level, right? Anytime there is an unknown or something we haven't managed, we're all feel like we're on, less solid ground there. But I think, again, the data have all been so reassuring. And I think really the quality of life data here sort of shines as far as knowing that really some of the side effects were mild and really did not impact quality of life in a major way. Okay, so I guess sort of to round things out, I would love to hear how you see this treatment approach being implemented looking ahead. So we're in clinic in a future state, and how are we going to kind of navigate with this data in mind?
I personally like to empower my patients. I think talking about these strategies up front, making sure patients understand why we're doing a particular test, I think they're more engaged in their own care. I think one of the things, we as an oncology community are going to need to decide is, are we only going to test for ESR1 every 2 to 3 months? Or would we do broader next generation sequencing ctDNA panels? And cost is always a consideration in all of this. So if we're doing these broader panels every 2 to 3 months for patients on therapy longer than a year, how is that going to work in clinical practice? So I do think there are a lot of questions. I think I would imagine a scenario where we do the testing ideally right before scans are performed. So when we're seeing the patient in clinic, we have information from both the liquid biopsy testing as well as the ctDNA testing. And then we fast forward even further into the future. I'd like to see ctDNA in some sense replace or decrease the frequency of scans to space those out. And I think in that setting, a ctDNA-based approach will actually be cost effective when we, in the future, potentially decrease the frequency of imaging.
Yeah, I totally agree with all of that. I think, looking ahead for me in clinic, I think having that, molecular data in conjunction with the imaging in sort of the near term would obviously be helpful when talking about next steps for the patient. But then looking ahead, I love that idea of really kind of leaning more heavily on the ctDNA data as we make decisions. So. Okay, well, thank you so much.
Thank you.